This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco with the Neurology podcast, here with Xavier Ayrignac to discuss his article in Neurology, Clinical, Radiographic, and Immunological Features of Patients with CTLA4 Deficiency with Neurological Involvement. Xavier is a professor of neurology at the University of Montpellier in France, and he last joined us on the podcast on October 6, 2022, where we discussed his article, Common Genetic CNS Disorders Masquerading as Neuroinflammatory Disorders. And I just want to say that I love that title. It really helps encompass how confusing these disorders can be, but they're definitely out there. We have to pick them up. During that episode, we actually talked about CTLA4 deficiency and its implications from a neurological perspective. But I'm super excited to dive into that cohort a little bit more. Welcome back, Xavier.
Thank you. It's my pleasure to be back to discuss these results.
And so what was the major finding when we looked just at this cohort?
The key points of our results is that patients with an apparently acquired inflammatory and neurological disease may in fact suffer from a genetic disease. Importantly, I think perhaps the most important is that for we, as neurologists, we must understand that we can face patients with undiagnosed genetic conditions like CTLA4 deficiency, and more importantly, the recent progress of therapeutic in the therapeutic field of genetic disease suggests that these disorders can be treated, and perhaps it's the most important thing.
And I think as I was reading through your article, I was most humbled by the fact that this disorder, some of the other ones, can really mimic some of our inflammatory diseases like demyelinating multiple sclerosis in terms of its clinical MRI, even its CSF findings. So I agree, it's out there and they're treatable. We've got to be aware. Maybe we could take a step back and just talk about CTLA4 deficiency more broadly. It's not something that we commonly see. What's the function of that gene? How does it usually present outside of its neurological complications?
CTLA4 is a transmembrane receptor. It's expressed by CD4 T cells, and CTLA4 acts as part of immune response, and it is known as the well-known immune checkpoint inhibitor. It acts as a negative regulator of immune response and control this immune response. CTLA4 deficiency is an autosomal dominant disease in patients with this CTLA4 deficiency. The natural suppression of immune response does not occur, and patients are prone to exhibit an overall immune dysregulation. This immune dysregulation may lead to immune deficiency with hypogammaglobulinemia, recurrent infection, but also lymphoproliferation, autoimmune diseases, and sometimes neurological impairment and cancer.
And so I'm hearing a couple things there. I love that word, immune dysregulation, because it seems to be causing an immunodeficiency and autoimmune disease, which we know can co-occur. And I think maybe another piece that I took away was it hits multiple systems. So these patients usually will have multi-system involvement in terms of hematological, GI, rheumatological symptoms. Is that right?
Yeah, completely. Patient can usually, the disease begin in the early childhood, but it can begin from early childhood to very late onset, sometimes 40, 50 years old. And usually symptoms begin with autoimmune disease. It can be autoimmune cytopenia or other autoimmune manifestation. It can also encompass respiratory diseases, gastrointestinal disease. And usually when patients grow old, they can also suffer from recurrent infection during adolescence and adulthood. And then, after years, they can suffer from solid organ involvement, such as neurological involvement.
And maybe this would be a perfect segue into those neurological symptoms. So what do we typically see, and when do those neurological symptoms usually come about? Is that early in their disease course, or is that something that's usually later on?
Yes, usually it's later on. In only one case, one patient had isolated neurologic symptoms. If this patient really exhibits a CTLA4, a real CTLA4 deficiency, perhaps she may have an MS and no symptoms of the CTLA4 deficiency, since we know that genetic penetrance is incomplete. But usually, patients suffer from the systemic disease many years before neurological symptoms and neurological involvement. But you have to understand that in some patients, neurological symptoms occurred just few years, months after the beginning of the systemic disorder. So it's not always so clear. In some series, around up to 6% of the patients began CTLA4 deficiency by the neurological symptoms.
Okay, so most of the time we're seeing this kind of multi-system disease, and then months to years later, neurological symptoms. And what kind of symptoms do we see? What kind of clues or red flag symptoms can neurologists be on the lookout when patients are coming into their clinic?
Well, from the neurological point of view, this is the main problem because symptoms are mostly non-specific. It can be headaches, it can be seizure, it can be motor or sensory deficit. So it's not very specific, but you have to be aware when patients have the systemic part of the disease. So you have to look deeply for autoimmunity, for recurrent infection, and so on.
So a wide range of symptoms. How about in terms of MRI or CSF changes? Do you guys see any patterns in your cohort?
It's very interesting because from the radiological point of view, you have, I will say, 2 to 3 typical MRI features. First, patients may have very large pseudotumoral lesions with marked gadolinium enhancement. The majority of the patients have that kind of lesion, and notably at the cerebellar level, you will look at the paper. The lesions are very unusual for other neurological diseases. Besides, you also have very small punctate lesions, and some of these punctate lesions are reminiscent to those we can see in multiple sclerosis, for example. But one clue is probably that there is usually leptomeningeal enhancement. And I said before, the cerebellar involvement is very, very not typical, but very peculiar. And you can also have spinal cord involvement.
So a few pieces there can help us clue things off. One, meningeal involvement is a little less common in our demyelinating pathologies like MS. And then tumefactive lesions, maybe especially in the infratentorial structures. That's also a clue here that should point us towards this.
Yeah, probably. And the fact is that with that very expensive lesion, with those pseudotumoral lesions, what's interesting is that like in some pseudotumoral demyelinating lesions, you have very large lesions, but few symptoms. And some patients with very large spinal cord involvement have, in fact, very few symptoms.
Okay, that's really helpful. That mismatch can be another clue. How about CSF? Did anything in particular pop there?
It's complicated because there are a lot of CSF abnormalities, but they are not specific at all. In approximately 2/3 of the patients, you may have oligoclonal. You can have oligoclonal bands, and can have slight elevated protein levels, and the cellularity is usually around 30 to 40 cells. So it's not very specific, even if you compare, for example, to MS, patients usually don't have elevated white blood cell counts.
And I think in your paper, you guys had 3 patients who underwent brain biopsy. Did those pathological changes help make the diagnosis at all?
Well, it's one of the main problems, I think, because usually the pathological analysis is unspecific, and you can see high cellularity, you can see an inflammation, but it's quite rare that the pathological results give you the results. One important thing, in my opinion, is that usually you don't have demyelinating features on the pathological analysis.
But I think a really helpful point here is, considering genetic testing before we move forward with the biopsy, because lots of the times it won't give us the answer in these really complicated genetic diseases that can masquerade as these neuroinflammatory diseases. Is that right?
Yeah, completely.
I know you touched on this a little bit in the beginning. You said that CTLA4 is an autosomal dominant disease, but an incomplete penetrance. So we may not see things on a family tree when we go through a family history. So how do you approach testing in your clinic? What kind of screening do you do? Do you start with panels, then whole exome, whole genome, things along those lines?
There are two main problems. The first, as you said, is incomplete penetrance. And the second is that given that we work on the field of co-dystrophy and genetic leukoencephalopathy and on the field of inflammatory diseases, we face a lot of distinct diseases with distinct presentation and who have a genetic disease. So we do not perform Sanger sequencing and single gen analysis, but instead we perform panel analysis looking for almost all the known causes of genetic leukoencephalopathies and all the possible causes of apparently neuroinflammatory diseases. It's around 250 genes that are analyzed. And when the panel gene analysis is unconclusive, and when we deeply think that it can be genetic and we have no other alternative diagnosis, we usually propose a whole genome analysis.
And then I know you had a small cohort in your paper, but what did you guys see in terms of treatment and treatment response?
The majority of the patients were treated with abatacept, which is a CTLA4 fusion protein. From the neurological point of view, all except one patient had good response, and they did not suffer from any new neurological episodes, and the systemic condition was also well controlled with CTLA4 fusion protein.
And does the mechanism of action make sense with CTLA4's function?
Completely, since the fusion protein in some way replaces the CTLA4 protein.
I think it's fun when we have our medications are targeted. It makes sense with the pathophysiology, and then we're seeing the clinical and radiographic response. It really makes things rewarding.
Yeah, and what's fun is that for sure it has been developed for autoimmune diseases, including, for example, it has been tested in multiple sclerosis, but it was not conclusive in the field of MS.
And I think some of our rheumatologists use this in other autoimmune diseases, right? They were the first to use this class of med.
Yeah, and they still use in certain conditions. For example, in rheumatoid arthritis, they sometimes use abatacept.
Well, Xavier, I think it's a perfect way to end this hopeful light that we have this ability to manage these genetic diseases when we properly identify them. So thank you so much for your time. Thanks for reviewing this really rare disease. It keeps me up at night that I've missed this. But as we learn more, as we see more, I think we're going to get better as a field. So thank you, and thank you for all your work on this. For our listeners, I encourage everyone to check out the article in Neurology titled Clinical, Radiographic, and Immunological Features of Patients with CTLA4 Deficiency with Neurological Involvement. Xavier, thanks again.
Thank you, Justin, for the invitation.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.